Welcome to your daily guide to your new knee replacement. My name is Brett Levine. I'm an assistant professor at Rush University Medical Center, and I am going to take you through your daily guide to your knee replacement. This will cover the preoperative aspects, the immediate postoperative aspects, and upon discharge, what you should expect and what should be expected of you. To introduce my staff first, I'd like to introduce you to my administrative assistants, Stephanie Palomares and Alicia Ramos. They are the people that will likely be taking care of scheduling surgery for you, your preoperative visit, your postoperative visits, as well as facilitating the attendance of a medical clearance visit that you'll need with a primary care physician, either at one of the hospitals that you're having surgery or with your own medical physician. Physician extenders that are part of the practice include Emily Stauffer, Crystal Wasakis. Emily is an NP, and she will be in charge of preoperative visits, as will Crystal, and they will see you preoperatively to go over a lot of the risk benefits alternatives of the surgery, as well as show you a little bit more about the procedure itself. And they may be involved in rounding on you postoperatively, as well as assisting in the surgery. They help me perform the surgery and take care of our patients so we can provide excellent care to you pre and postoperatively. Our main phone number is 312-432-2466. The fax number is listed here. And we do have a secure email, which is morjointdoc@rushortho.com. So feel free to call or email. If you email, we'll get right back to you. If you call, you can leave a message. Or if you select 0, it'll take you through a series of menus that could ring through the person who's taking care of the practice on call. We do have 3 office locations at Rush University, Rush Oak Park, and Prairie Medical Center. Myself, as the physician, I am at Rush University and Prairie Medical Center only. Crystal sees patients at Rush Oak Park for us, and you can still follow up there to see her for postoperative visits, preoperative visits, whatever you like. If you call the office, they'll be able to direct you on the days that we're at each location. Again, these are the addresses where you can see us pre or postoperatively. And you may follow up at whatever office is easiest for you. So whatever office we see you the first time doesn't necessarily have to be your follow-up office. Similarly, wherever the surgery is done, you don't necessarily have to follow up at the office that's located at that site. You can follow up with us at any one of these locations. That brings us to the hospital locations. We have Rush University, which is downtown on Congress Parkway. You check in on the 4th floor as you pull into the parking garage. You enter the hospital, and there's a desk right there that will get you checked into admissions. Elmhurst Hospital is on Brush Hill Road at the junction of 290 and 294. It's right at that hub at the corner of York and Roosevelt. You check in on the 2nd floor. Again, as you enter the hospital, they'll direct you where to go. This, again, is the location for surgery. You can choose whatever location is easiest and best for you. I do not have a personal preference to either location, and you can choose either one and follow up at whatever office afterwards. As a means of full disclosure, as you go through this talk, I don't mean to bias you towards any one of these products. I truly believe that a well-done joint replacement functions very well regardless of the type of implant that is placed. I am a consultant for Zimmer, Link, OrthoView, and McGraw-Hill, and I do receive some research funding from Zimmer, Artelon, and Biomet. I have published 2 books, and these are the royalties that I receive from Human Kinetics and Slack Incorporated. So a brief outline of what we're going to cover in this talk will be medical clearance, preparing for surgery, the night before surgery. These are all your preoperative aspects. Then we're going to discuss briefly the hospital stay, day of surgery, day 1, 2, 3, and then the discharge. And then we'll run through the postoperative recovery, about going home, your rehab, physical therapy, and then following up in the office. As part of our preoperative phase, essentially at this point, you've decided I want to have a knee replacement. So what's next? There are a few things that you have to do. There's medical clearance, which means you're basically going to have to get a series of tests, and we'll cover that in the next slide. But you're going to need to get a series of tests by a primary care physician, either your own or one at the hospital, and get cleared for surgery, as well as potentially following up with any subspecialist that you have. This is an elective procedure, so you do not want to go through the surgery unless you are 100% optimized on your medical conditions that can be optimized. And that includes things such as diabetes, weight loss, stopping smoking. Those are important things before surgery that minimize your risk for complications after surgery. Then there's also the preparing for surgery phase. This is getting yourself mentally prepared. You have to be prepared to undergo a relatively grueling surgery and postoperative rehabilitation. And if you're not mentally prepared, this is your time frame in this preoperative series of weeks where you really want to get yourself psyched up for the operation. There's also an element of prehab, which we'll cover, which basically is rehabilitation before the surgery that you can do, as well as discuss what you should do the night before your operation. So on to medical clearance. You have to see your medical doctor or a primary care physician. They're basically going to do a history and physical, which will cover some basic blood work, an EKG possibly, a chest x-ray possibly, and then possibly some other tests that they decide they want to order for you. These are important tests. We defer to your medical doctor regarding the medical clearance, and we allow them to do whatever it is that they feel necessary to get you optimized and cleared for surgery so you could be at the lowest risk possible after surgery. All of these things will be worked out with your medical doctor. We will give your medical doctor a checklist of the basic stuff that we need to have done. And then the rest of the things they will get will be based upon their discretion. If you don't have a primary care doctor, again, we'll find one for you, or we'll choose one at the hospital that you're going to so that they can potentially follow you post-operatively at the hospital. In regards to subspecialists, if you do have multiple medical problems, you may be asked to see a cardiologist to do possibly a stress test or an angiogram. You may need to see an endocrinologist if you are a diabetic, or your blood sugar or your endocrine hormones are out of line, which could include even the thyroid. And if that's the case, an endocrinologist may be able to get those in line for you again to decrease your risk. While it's not an absolute contraindication to surgery, a hemoglobin A1C greater than 7.5 does place you at higher risk for postoperative complications. So for those of you that are diabetics, ideally we'd like to see that hemoglobin A1C be less than 7.5 if at all possible. And we'd like to see that worked on, and that could be controlled nutritionally and with a little bit of exercise, which your endocrinologist can help you with. As far as nutritional things, if your BMI is greater than 45, your risk may outweigh the benefit of the surgery. So over a BMI of 45, it increases your risk to almost 30 to 35% you may have a complication after surgery. If your BMI is over 50, then you may wind up even at a coin flip that a major complication could happen after surgery. And we strongly encourage you to work on weight loss, see your nutrition, to work on optimizing things. The greater your BMI, in conjunction with other comorbidities, really puts you at high risk. So if you can lower your BMI, optimize other comorbidities, then you can really get your risk down. So seeing a nutritionist might help with that. Also, a lot of patients who do have elevated BMI, which is your body mass index, often are actually malnourished. Protein levels can be quite low. So seeing a nutritionist, they might be able to guide you with a better diet that will ultimately lower your BMI and help with your protein levels. Lastly, regarding a dental appointment, if you do have any dental concerns, you should see your dentist. Make sure there's no underlying infections in your mouth, as these could lead to postoperative complications and infections as well. So now that we discussed the medical part of it, mentally, are you prepared for surgery? So the things we really like to cover, and at this point, if you're already signed up for surgery, you should have already thought about these things. We like to get patients mentally prepared by making sure that you've tried all forms of non-operative management. You've done injections, anti-inflammatories, and you're 100% sure there are no other options and replacement is the end of the line for you, and you're ready for surgery. You need to understand the risks of surgery. There will be a separate PowerPoint that you'll be able to pull up on our website that will discuss the specific risks of the surgery, and it's important to go through these because these are elective procedures and they're not risk-free. Nothing in medicine is 100% risk-free, and nothing in life is risk-free. We basically have the motto of low risk, low reward, high risk, high reward. Injections and anti-inflammatories tend to be relatively low risk, and they give you a low reward in that they treat the symptoms of arthritis. Surgery is a higher risk, but the reward is that you get rid of the arthritis and can have a long-term, excellent functional recovery if you do everything that you need to do, and we do everything we need to do on our part. So that brings us to expectations. Do you have the appropriate expectations? You really need to think about this. Expectations include the fact that this is a knee replacement. It's metal and plastic. It is not going to make you feel like you're 20 years old again with your knee. It is going to make your knee feel better than it is at this time with the arthritis. If you work hard in rehab, you should get a better range of motion than you have now. And you should be able to get back to normal activities like walking, cycling, hiking, doubles tennis, golf. If you used to ski, you can ski. Rollerblading, those kind of things you can get back to. But running and jumping and high impact activities are not great for a replacement. Nor is returning to sport activity too early, which means we typically like people to wait 6 to 12 weeks before you consider returning to higher level activities like a long hike, a long bike ride, playing a full round of golf. There's no one going to give you a medal for being the first person to play a round of golf after your surgery, so it's important to remember to take it easy, have reasonable expectations, and we'll cover your post-operative recovery in a few slides down the road here. The other thing you want to do is you want to make sure that you've read all the paperwork that we've given you in the preoperative folder. It has a lot of information about discharge. It has a lot of information that's going to be covered in this talk, but information that's outside of this talk. And it's important to make sure you go through that folder so you're 100% prepared. Then you also want to think preoperatively about what your discharge plans would be. We prefer all patients go home if possible. That's not something that we enforce. If you can go home, there is no place like home. There's less chance of picking up infections, less chances of being around sicker patients. So home to us is the best place for you, but if you can't go home and you need to go to a rehab or a skilled care facility, you want to think about that, maybe discuss it with your insurance company, and maybe even have a couple places in mind that you visited that would be acceptable places for you to go after surgery. So what about this concept of prehab? Prehab is rehabilitation before the surgery. Now, if you could do everything that you wanted to do before the surgery, you wouldn't be having surgery. So these are things that you want to do within a reasonable degree of torturing yourself preoperatively. So you really don't want to put yourself in a tremendous amount of pain, but ideally, if you can, you'd want to focus on some quadricep strengthening exercises. That means leg lifts and straight leg raises and leg extension exercises. Hamstring stretching is really good, so trying to push your leg flat into a bed and get it as straight as possible, and make sure that you maximize that range of motion. Bicycling or an elliptical machine to get your aerobic stamina up, that's probably the best thing that you can do. Or if you have access to a pool, that is by far the best thing. But any of these things will help keep up your strength, keep up your stamina, and help you out. Certainly keeping your upper extremity strong is a good idea, as well as the leg that's not having surgery, keeping that strong is a great idea so that it's there to support you post-operatively. You can start physical therapy before surgery. At your preoperative visit, we will give you a prescription for physical therapy. I think it's a great idea to go to a physical therapy place before surgery. Learn the exercises when you're not in the pain of having had the surgery, as well as know what everything you need to do post-operatively, and get an idea of who your physical therapist may be after surgery, and make sure that you actually like that facility so it'd be someplace that you want to go to after surgery. You want to maintain a good diet before your surgery as well. Try to keep your pre-op weight the best you can. Make sure you eat a good high-protein diet and a well-rounded diet so that you're coming into the surgery full strength. Some of the things we also do to get you prepared for surgery. After your pre-operative visit, we typically will give you all your prescriptions. We ask that you start a stool softener 48 hours prior to the surgery to help prevent post-operative constipation. All the pain medicines are very constipating, and certainly if you have any trouble with constipation, we'd want you to start on a Colace or a Miralax or a Senecot type drug before surgery, which you can buy over the counter and start preparing yourself for the future that maybe holds some significant constipation after the operation. The other thing that we do ask you to do is we ask you to get a soap called Hibiclens. It's a chlorhexidine soap. That's chlorhexidine soap. You can get this at any pharmacy, CVS, Walgreens, any of those places, and basically we ask you to shower with the soap. You can substitute some of the antibacterial soaps. I know Dial does have one that's antibacterial that you can use in place of the Hibiclens, but you do want to shower with your whole body. You don't have to necessarily do your face or hair because it could be a little caustic. And you want to do this each day for 3 days prior to your surgery. This has substantial implications on post-operative infections and can lower it by 30-fold if you do this showering appropriately. So this is something that you should definitely do. We suggest this for all patients. We will give you your prescriptions at your preoperative visit, and so we suggest that you get those prescriptions and set up your therapy and have your medications waiting for you at home if you were planning on going home. If you in fact are not planning on going home and possibly to a rehab, then we may not give you your medication prescriptions because you may not need those medications after you get out of rehab. So we would give those to you upon your discharge from the rehab for whatever balance of medications you need at that time. Another thing we may ask you to do is take a trial of OxyContin, which is a very potent pain medicine, and give you a very low dose. And we suggest you take it a day or two or up to a week or so before your surgery, just to make sure it doesn't cause you substantial nausea, which it can do. So we suggest you take it at night after dinner before you go to bed, and if you do get nauseous, you'll sleep it off and it'll be gone in the morning, and then we just won't give that medication to you after surgery. If you're older than 65 years old, we may not give you this medication as well, and if you are also very naive to narcotics, haven't taken any in your life, we may not give this to you because, again, it can be very nauseating, and it's kind of a little bit on a case-to-case basis, but feel free to ask us about the OxyContin. If, in fact, you've trialed it and you have not had any trouble, you can take an OxyContin pill on your way to the hospital. It just kind of cuts the nerves a little bit, gets the pain relief starting before we even get to the surgery. So that's a very reasonable thing, but not a mandatory part of the process in getting ready for surgery. So the night before surgery, what are your responsibilities? Everything here is listed on this slide, but most importantly, after midnight, there's nothing that you cannot eat or drink anything. The hospital typically will call you to remind you of this, but it's very important to not eat or drink after midnight. It could be problematic with your anesthesia, and you can lead to aspiration during the course of the surgery, which is very, very catastrophic for you. So nothing to eat or drink after midnight. You want to check with your medical doctor on what medicines to hold or continue. Some of your medicines, your medical doctor may tell you to take a half dose the day before or stop taking a couple of days before. But those are things you definitely want to ask your medical doctor. If you do have any questions, you can call our office, but we may not be the best people to answer that question, but we'll do our best for you. As far as anti-inflammatories, Advil, Motrin, Aleve, those kind of medicines, Celebrex, Voltaren, there's a whole list of them. Essentially, all the anti-inflammatories you want to stop at least 5 days before the surgery, because this can lead you to excessive bleeding during the course of the operation or in the immediate post-operative time frame. Same thing with blood thinners. You do want to stop those earlier, and you want to check with your medical doctor. So if you're on a blood thinner, Coumadin, any of the oral agents like Xarelto, Eliquis, Pradaxa, any of those type of medicines, you do want to check, including Plavix, when to stop these blood thinners per your primary care doctor. Some may be suggested to go a little bit longer. Some may need to take shots of a blood thinner while you're off the oral blood thinner. It's important to check with your medical doctor on this. Again, if you contact us, we'll do our best to help direct you, but you may be redirected to your medical doctor for further discussion on this matter. If you're feeling ill, you have a cold, you're just not feeling great, you should call to alert our team. So within a few days of the surgery, if you're not feeling great, call to alert us. We can bump the surgery and move it to another day and do it when you're ready. You definitely do not want to go into the surgery feeling down or with the start of a cold. Just not a great idea. We can delay the surgery for 4 or 5 days a week and then get you back on the schedules when you're feeling better. So important to let us know about these things. And then the night before or the day before, the hospital will call you and tell you exactly what time to arrive for the surgery. That's the team you need to listen to. Nobody else is going to direct you at what time to be there. If you hear anything else, not a great idea to listen to it. Listen to what the hospital says, and I strongly encourage you to try to be there even 30 minutes before that and plan for traffic or other contingencies. But better be there a little bit early than to be late, because if you are late and the day is moving along and it's late enough, it's possible that your surgery could be canceled if you're not there on time. On the day of surgery, what you'd expect. The anesthesia that we typically use, we like to use a spinal or an epidural block with twilight sedation. What does that mean? Basically, that means you get a shot in the back. And they either do a one-time shot or they'll put a catheter in your back to use during the course of the entire surgery. And it numbs you up from the waist down. They'll also give you some twilight sedation so you won't remember anything, and you'll sleep through the entire surgery and wake up in the recovery room wondering if we even started. The advantages to spinal and epidural have been shown in a lot of our literature in joint replacement. There's lower risk for blood clots, lower risk for transfusions, lower risk for nausea and vomiting after surgery. Now, not all patients may be candidates for spinal or epidural anesthesia. If you have previous back surgery or bad back arthritis, they will try once or twice and then move on to a general anesthetic. We try our best for the regional anesthesia. I do think it's best for you. If I were to have surgery, I would have a regional anesthetic, but it's not for everybody. And the anesthesiologist will go over those risks and benefits with you preoperatively in the holding area. If you wanted to meet the anesthesiology team preoperatively, an appointment with the anesthesia clinic could be made at either of the hospitals, and you can meet them preoperatively. Surgery itself usually takes somewhere between 60 to 90 minutes of operating time. We use a thing called a tourniquet. So essentially it's this cuff that goes around your thigh and squeezes really tight. So there's very minimal blood loss during the course of the surgery. Occasionally, if your thigh is really big, then we could run into the problem that the tourniquet doesn't work, and there may be a little bit more blood loss during the surgery. But otherwise, blood transfusions are rarely needed during the course of the operation because of the tourniquet. You may also have a little bit of thigh pain after the surgery, a little bit up towards the groin and the upper thigh, and this is likely from that squeeze of the tourniquet that is on there for the 60 to 90 minutes to provide us with a bloodless field as we do the procedure. When you get to the recovery room, you'll spend somewhere between 90 to 120 minutes in the recovery room. This is where the nurses will get you settled down. They'll go ahead and take an x-ray of the knee in the recovery room to make sure everything looks good. And they'll get your pain and nausea under control if that's going on. They'll usually allow a family member to come in at some point and say hello to you in the recovery room, although it depends upon how busy the recovery room is and which hospital you're at. You'll be groggy at this point because you've just woken up, but you should have very minimal pain because you've had that regional anesthesia, so you won't really be able to feel your legs yet, but you'll be waking up and actually starting to feel pretty good by the time you're leaving recovery room, and the sensation to the legs will be slowly starting to come back. While you are in recovery room and being transported there, I will discuss the surgery with your family and let them know how everything went, and they'll be instructed to come see you as soon as the recovery room team allows them to come back. From the recovery room, you'll move up to your room, and once you're comfortable in your room, you'll be given a clear liquid diet. And if you feel good, I encourage you to go slow because there still can be some nausea. You can slowly progress to a solid diet, so a clear liquid for, say, lunch, and then solid diet for dinner, or clear liquid for dinner and a solid snack later in the evening. So you just want to take it nice and slow because there can be some nausea, and even though you might be feeling really good at that point, best not to overdo it on a heavy meal right after the surgery. If you do arrive to your room early enough, physical therapy will see you, and or the nurses will be able to get you up and sit you in the chair or at least sit at the side of the bed. It's a great idea the first night to be able to sit at the side of the bed and dangle your feet at a bare minimum. It shakes the cobwebs a little bit, and it makes it a lot easier to get ready and get going the next day. So I think it's a great idea to try that. And I highly encourage you that even if PT doesn't see you, to ask your nurses to at least sit you at the side of the bed. First time you get up or sit at the side of the bed, you're going to get dizzy, maybe even a little bit lightheaded. So it's normal. Take your time in standing up and then go ahead and get going. So again, that's probably why it's good not to have a heavy meal before you get up for the first time, because you will get a little lightheaded, a little dizzy, and that can lead to some nausea. So just take it easy, but getting up the first day is very important. Getting up the first day does decrease your risk of blood clots by 30-fold. So even sitting at that side of the bed is important, and we highly suggest you do it. The benefit of getting up within the first 24 hours, again, is about a 30-fold reduction in blood clot development after surgery. So a very important aspect of your surgery, something that you'll need to do. What else should you expect in your room? Well, try to get some rest if you can. I know it's going to be difficult, but try to get some rest. A sleeping pill is ordered if you need it. You could take your pain medicines if you start to feel pain. Don't let the pain get ahead of you. So as you start to feel little twinges of pain as the spinal's wearing off, make sure you get that pain medicine going. There'll be something ordered orally every 4 hours. In between that, you can get something as well. And then there's even stuff through the IV if it gets really bad. We know this is a very painful operation. We know this is a very painful recovery, but we need you to move. The more you move and the more you get around, the better it is. So take the pain medicine, stay ahead of it. While you're in bed on that first night of surgery, have your leg propped up on some pillows, and put some ice on the knee. Depending upon where you are, you may have an ice machine or just ice packs, but either one of those, the cold therapy works very well with swelling. And the pillows need to be down by your ankle. You do not want to put pillows underneath your knee. If you put pillows underneath your knee may get stuck slightly bent, and then it'll be a difficult time recovering that after surgery. So really you want to keep those pillows down by the ankle, and while you're in bed, focus on pushing your leg straight so that the back of your knee hits the bed and you get full extension of the leg. The bending will come when you get out of bed. Really focus on what to do in the bed, which is extension. We do not use any of the bending machines, the CPM machines. The literature has not shown that it is a great option to use. It can be relatively expensive, and so we do not use any of those bending machines anymore. This certainly can be done between you and the physical therapist, and if you work hard enough, those machines are definitely unnecessary. So on the first night of surgery, get ready, get some sleep. Tomorrow's going to be a really big day. Typically, I will come around and see you that night of surgery in your room, depending upon if you're up in your room, out of the recovery room, in a timely fashion. We'll cover some of those things that I discussed as I see you. Again, I will remind you that day one is a big day. And this is now where we'll discuss day one. So it begins here. This is the toughest day. You're really going to get out and really get moving for the first time out in the hallway, probably. Maybe your second time, depending upon if you had therapy the day before. But the anesthesia is going to be completely worn off. You can expect a fair amount of pain. And it's very, very common to have a lot of pain, particularly as you're moving, particularly as you're trying to bend the knee. In fact, I would go so far as saying that if you don't feel a lot of pain, you're probably not working hard enough in your physical therapy on your first few days after the operation. We know it hurts. Use your pain medicine. We typically use Norco, which is a hydrocodone-based medicine. We'll often use OxyContin. There'll be some morphine possibly, an anti-inflammatory called Celebrex. So we'll attack the pain from all different angles, and we have lots of different other medications that we can add or substitute in depending upon your allergies and your pain tolerance. But it's very important you take the pain medicine, and even more importantly, you have to get moving. If you don't get moving early, the knee will stiffen up, and it makes it very difficult for the long-term recovery. The more you move early, the quicker it gets better. So again, take those pain medicines, stay ahead of the game, ice and elevate your leg when you're sitting, even when you're in the chair, have them prop it up on the chair and get some ice on there, and that'll really help you. When you're out of bed walking, the therapist will go over this with you many, many times, but you really want to focus on walking normally. So put your leg out and go heel toe as you walk. It helps push your leg straight. If you do that, you'll get used to walking normally, you'll break some of your bad habits, and you'll get back to a normal gait pretty quickly. I know that'll be a painful way to walk at first, but it's a very important thing to keep in mind and do the best you can. Did I mention stay ahead of the pain? On day one, really be consistent with the pain medicine. In the first 10 to 14 days, taking pain pills every 4 to 6 hours is normal. If for some reason you don't need them, that's okay. But if you really want to get pushing and you really want to get the rehab as best as you can and get a maximal range of motion, take the pain medicine. Be consistent. You will not get addicted. Eventually, as the pain dies down, you just won't want the pain medicine anymore. But be consistent and stay ahead. You're not going to damage your knee. And I can't reiterate this enough. There will be pain when you bend your knee, but you will not be damaging it. And you have to block out of your mind the fact that it hurts. It's not equal to causing damage to the knee. So pain does not equal damage to the prosthesis. If you push through it early on, you have great long-term success and the best possible recovery. So progress, you're basically going to walk and possibly do some stairs depending upon how you do and if you walked the day before. Your case manager for the hospital or social worker will come by, they'll review your progress. Discharge planning will begin. And if you clear therapy, you can actually go home the day after surgery if you're doing that well. It's not that you have to, but if you feel well and you want to go home, we won't stand in your way if you're able to do the stairs and walk around the nurse's station. If you need a rehab, then at that point in time, arrangements and strategies for getting you to rehab should be starting so that you can get out of the hospital in a timely fashion. Again, as getting out of the hospital, well, we're not trying to push you out. It is better for you. It is better to be out of the hospital where you can get the worst bugs and into your rehab or home as soon as possible. Your dressing typically will be changed at that time. There's typically a drain that's placed in your knee to help remove the blood after the surgery. That also will be removed, and a new dressing will be placed. We try to put on an ACE wrap to help with compression on the leg, or one of the long TED hose that go up above the knee onto the thigh to help keep some compression while you're in the hospital. And we like to keep that wound covered at least while you're in the hospital. Moving on to day 2, you're past the worst day. This tends oftentimes to be a turning point. People get a little bit down and are a little discouraged on day 1, where they did pretty good the first day because the spinal was working. The day 1, which, to clarify, on the day of surgery we call that day 0. After surgery, day 1, and now you're on to day 2. That day 1 feeling can sometimes get people down. Usually when you wake up after a good night's sleep on day 2, you feel a lot better. Again, don't get overconfident. Stay ahead of the pain. Keep taking that pain medicine regularly, and it will help you. Physical therapy will continue, and they'll work more on stairs. They'll use a walker, a cane, or crutches, depending upon what you need, and you're going to recover at your own pace. Don't look around the room and worry, oh my God, I'm behind this person, or I'm ahead of this person. Just push yourself the most that you can do. So, not to sound cliche, but be the best you can be. The more you work, the better you recover. And that will come at different paces for each person. There again is no medal for the first person to go home, no medal for the first person to climb stairs. You recover at your pace. But the therapists are there to push you so that pace isn't too slow, so that it compromises your long-term outcome. Remember, at this time, your appetite is not going to be great. Try to eat some healthy options if you can. Protein bars, protein shakes are great for the recovery after the surgery, but you're not going to have a great appetite. You're not going to be burning the calories you typically burn because you won't be doing as much. So don't panic. Your appetite will come back. The pain medicines also suppress the appetite a little bit, as did the anesthesia. Your appetite will come back, but try to eat healthy the best you can to help with your recovery at this time frame. One thing that may be ongoing at this point on day 2 is constipation. So we give you stool softeners, as we mentioned preoperatively, that continues postoperatively. Suppositories may be necessary, or an enema. Plus, whatever is your normal routine. If you have certain things you like to eat or drink that help get things going, I think it's important. Constipation can be a real source of problems after surgery. You just don't feel good, and really can slow you down quite a bit. On the very rare occasion, it can come to the point that you can wind up with a small bowel obstruction, where they have to put a tube down your nose to help keep you from throwing up. Again, the more you move, the lower this risk of constipation. Take the stool softeners and continue the pain medicines as you need them. So just something to prepare you that constipation can be a problem on day 2. Where you expect it, we try to stay ahead of it as well. And at that point on day 2 as well, if you feel good and you clear therapy, you'll be ready to go home, and we'd be okay discharging you on day 2 if you're ready. If you need to stay a 3rd night, that's okay. And if you're going to a rehab, you will have to stay at this point 3 nights. There are some criteria that are changing that may happen that you can be able to go sooner, but currently, if you want to go to rehab, you basically have to stay a 3rd night. On day 3, again, you should be feeling better. Things are starting to fall into place more. If you're already home, you should again also have the same feeling. Things will be falling into place. Should be moving around at home, getting up and down to the bathroom, going to the fridge, eating dinner, that kind of stuff. So by day 3, however, typically discharge will occur or have already happened. Your pain is going to be better, but it still hurts when you do your physical therapy, so stay ahead of that. The swelling may get actually a little bit worse on day 3 and peak somewhere around a week after the surgery, and then by 2 or 3 weeks it will go down. So don't be surprised if you look down and your leg is huge. As you walk more, gravity will pull that fluid down into your foot and ankle will swell. That's why we suggest while you're up moving around that you wear a compressive stocking or the ACE wrap during the day, and then you take it off at night when you're sleeping. At this point, you can shower with your wound uncovered. If you're home, you can do it uncovered. At the hospital, they're typically going to have you cover it. You can shower, and then they'll change the dressing. And then when you go home, if your wound is nice and dry, you can leave the wound open to air if you want. We cover it with a glue, and we will allow you to shower after surgery. Some of the nurses may suggest you don't do that. It's okay whether you have sutures or staples. We cover it with the glue. Go ahead and shower. Just don't scrub the wound. Don't put any lotions or creams over the wound, but go ahead and shower and keep the leg clean. So bon voyage at this point. All discharge plans should be finalized by day 3. Occasionally, people will stay an extra day or 2, depending upon rehab placement, depending upon how you're doing. If there's any medical issues or complications, or if you're just having a tough day, it can carry over, but don't let that get you down. It happens from time to time. But typically by day 3, most people are ready to go home and do go home or to rehab. After this, however, you still have to work hard. So even though there's pain during the first couple of weeks, it's the easiest time to physically regain your motion. After a couple of weeks, the scar tissue starts to form. So if you can really get it moving early, you'll get ahead of that scar tissue, you'll get a great range of motion, and you'll love your knee replacement. Your goal is to get a minimum of 90 degrees of flexion and the leg fully extended by the time you come back to see us within 2 to 3 weeks of the surgery. At this point, don't get discouraged. It's easy to get down a little bit and say, oh my God, why did I do this? I can't believe he did this to me. Don't worry, it's going to get better, I promise. Day 3, things are starting to get better, but it's going to get a whole lot better. You're not even close to your full recovery at this point. Got to still work hard though. That's the most important thing. And I find myself sometimes feeling like I'm a coach, getting you ready for the big game. But at this point, again, you got to work hard. Discharge. Don't be anxious. If you're ready to go home or rehab, you're ready. You've been cleared medically by the physical therapist. It's okay to go home. It's okay to go to rehab. We're still going to hear about you. You'll be able to call us if there's questions. If you go to rehab, call us if there's questions, or have them call us. If you're home, call us or send us an email. Again, that email address is mrijointdoc@rushortho.com, or call our phone number, 312-432-2466. We'll get right back to you and make sure that everything is good. So don't be too anxious. We're still a phone call or an email away, and we'll make sure that everything is okay. Swelling is very, very normal after the surgery again. 7 to 10 days it'll peak and then slowly resolve. Your foot and ankle will swell. There's no doubt. This happens to everybody. Don't panic. It's going to be okay. If you are concerned, instead of rushing to the emergency room or calling your medical doctor, call us first. We'll get you into the office and just make sure and take a look at it to make sure that it is okay. We don't want to sound cavalier, but we have seen lots of patients, and we can tell you when swelling is concerning or it's not concerning. So please don't hesitate to contact us. You certainly can actually this is a secure email address. You can always take pictures of your wounds and email it to us, and we can get back to you and let you know what we think. Open line of communication is good, and we just don't want you to feel like you're being abandoned or be anxious to go home. But believe me, you're ready, and this is where the rest of your recovery is going to occur. Getting home, your family can take you home to rehab if that's possible. If it's not, then they will arrange for transportation for you to get home or to rehab. Typically, during the course of your hospital stay, therapy will guide you how to get in and out of a car, and to make that transportation process a lot easier. If you do need transportation, case manager and social workers are there to help you get that arranged. So don't panic. They're not just going to kick you to the curb with some cab fare. They'll make sure that you get home appropriately. If you are traveling a distance, we do have lots of patients that travel from other states or further south or north or west in Illinois. You want to make sure you just get out and stretch every couple of hours and pump the foot and ankles up and down quite a bit so that you're not being too static and you don't wind up getting a blood clot. It is safe to travel. You just want to make sure that you do stretch. Your wound will be covered on discharge, but when you get home, you can shower and then leave it open air. Again, it's covered with a glue. If there's no drainage, you can leave it open air. If there's any drainage at all, we do suggest you cover the wound. And if there is any drainage after a week or two, then we suggest you certainly call us and let us know. If the drainage is increasing at home, goes from very little to some or a lot, let us know. Just give us a call or shoot us an email. We'll make sure we get you into the office to discuss this further. If you are going to rehab, again, your family can take you to rehab, or you can use the transportation. That's up to you. And the case manager will help you with that. But if you're capable of going, your family can take you there. Your wound, again, will be covered on discharge. At rehab, we do prefer your wounds stay covered until you go home, only because rehab is oftentimes a lot like a hospital, and we really just don't want anything to get in there or you to pick anything up. So we do suggest you keep it covered. Again, you should be wearing your TED hose or your stockings, or your ACE wrap while you're up during the day, and then take that off at night. That goes for both, whether you're going home or you're going to rehab. All orders from the hospital will be continued at the rehab, so you don't have to worry about doing anything. You don't have to bring your medications. Just bring a change of clothes and an extended change of clothes for you for the time that you're going to spend in rehab to the hospital initially, and all that stuff will get transferred over there. All your orders. You can even have your family just bring the stuff over to the rehab if you want, so you don't necessarily have to bring extra stuff to the hospital. They could just bring it right to the rehab for you. So now that you're either home or you're even in a rehab facility, again, physical therapy is going to be the most important part of your recovery. It is your job after this surgery and your only job to work on your recovery, and that is bending and straightening a leg, walking as much as you can, and trying to eat right. So working hard early and often is the most important thing. Range of motion is crucial in the first 2 to 3 weeks after surgery, and if you don't get the range of motion going by even 6 weeks, then things may be tougher. Your swelling will subside, usually 2 to 3 weeks after the surgery. Occasionally will extend out to 3 to 4 weeks, but it gets better. Your leg will not feel so heavy, and it will not be so tough to bend as you get it working and loosened up. If you work hard and push through it, then things really get better. Keep your chin up. It's still going to get better. Work hard, range of motion, and then worry about strengthening. Get that motion first, and it makes it so much easier because the therapist doesn't have to push so hard on your knee every day. You can really get into the strengthening part, which is the fun part. Again, a little more on physical therapy as your staples or the glue starts to come off. Usually around 2 to 3 weeks when you see us in the office, we'll allow you to start putting lotion over the incision, and the glue will start to come off or the staples have come out in the office. This will improve your motion substantially as that skin loosens up. So you'll get an increase in 10 to 15 degrees of motion just after that. So we really would love to see you at 90 degrees minimum of flexion and near full extension by the time you 90 degrees of flexion and near full extension by the time you get to the point of 2 to 3 weeks after the surgery. Then you'll be well on your way. If by 4 to 6 weeks you're not over 90 degrees and don't have full extension, we may have to do a manipulation and anesthesia. There's a separate set of slides that will direct you to that you can look at on the website. But most importantly, again, you need to have this. The manipulation is basically bring you back to the operating room. We bend your knee a bunch of times, loosen up the scar tissue. Helps tremendously to get you kick-started if you need that. As far as follow-up goes, your first follow-up should already be set up. You should set that up pre-operatively. If not, in the hospital or when you get home or in rehab, call Alicia or Stephanie at 312-432-2466 to set up that appointment. Usually we want to see you somewhere between 10 to 21 days after the surgery so we can do a wound check. If you're traveling a great distance and special arrangements have been made, sometimes you can actually have the therapist do or the nurse take out your sutures while you're at home, and you don't need to do anything else. You'll be able to come back at 4 to 6 weeks to see us in the office for the next follow-up visit. So again, some of this stuff may be prearranged as a special arrangement, but that's something that would have been worked out already. So again, you should have that follow-up appointment, otherwise give a call and get that scheduled. So essentially this concludes our discussion on what to expect with your total knee arthroplasty. Hopefully you've gotten a lot out of this discussion. You can watch this through as a movie or click through the slides. But essentially, I appreciate you paying attention to this and listening through. There's some important pearls as you go through. I can't highlight enough that total knee replacement surgery is not an easy recovery. We do less invasive techniques. I think pretty much everyone nowadays does. And most importantly is making sure we have a good candidate for surgery, that you're mentally ready for surgery, physically ready for surgery, and medically ready for surgery. If you are, you'll do outstanding. And if you work hard, we'll do our part and get the replacement in where you need it. We will have separate modules that you can look through. So either contact us at morjointdoc@rushortho.com with questions, or if you visit our website, they may not all be up at the current moment, but there will be more as time goes on to cover various things about the different implants, a little more aspects about the surgery, maybe even some x-ray pictures, and other aspects including hip surgery as well. So I do appreciate your attention here. And again, any questions, do not hesitate to contact us. There's a shameless plug here for the book that we help write, which shows using Pilates to manage your postoperative rehabilitation. You can check that out further at the Human Kinetics website as well. Again, thank you for your attention, and you have a good day.